All right, excellent. Well, welcome back, everybody. Thanks for staying with us on this Friday afternoon. It's really a great pleasure now to introduce Dr. Amit Kashani to the Flaum Eye Institute as our guest speaking professor. Dr. Kashani is the Boone Pickens Professor of Ophthalmology at the Wilmer Eye Institute and one of the nation's leading retinal clinician scientists. Dr. Kashani's research involves developing novel imaging methods in human subjects to improve clinical care. Much of his work involves using OCTA to investigate retinal vascular disease, and his team has demonstrated qualitative and quantitative use of OCTA in evaluating diabetic retinopathy, uveitis, and other retinal diseases. He's also expanded his work to use ocular imaging to assess brain health and dementia. Recently, he became a lead investigator for the first clinical trial in humans to test a novel stem cell therapy for severe vision loss from dry AMD. Dr. Kashani completed his medical degree and PhD in neuroscience as part of the MD PhD program at Johns Hopkins University. He then traveled to USC for an ophthalmology residency, alumnus, go LA County, where he remained to do postdoctoral research in biomedical engineering. He then completed his vitreoretinal fellowship as a Heat Fellow at the Beaumont Retinal Consultants. He returned to USC to join the faculty, where he spent 6 years before moving to Baltimore, where he joined Johns Hopkins. Well, back and forth and back and forth. Dr. Kashani is a PI or co-investigator in multiple studies funded by National Institutes of Health and has published over 100 papers in the scientific literature. He's been honored as a leading international innovator in medical and surgical retina and one of the top 50 international rising stars in ophthalmology. Please give him a warm welcome today as he presents 2 lectures. One, stem cell-derived RPE transplantation for advanced dry age-related macular degeneration, and then optical coherence tomography angiography applications in clinical practice and research. Welcome, Dr. Kashani.
Let's go with this one first. All right, thank you, Dave. Let's see, right? Oh, I see, I got it. That works? All right, thank you so much for the introduction. Thanks for having me here and the whole team. It's been really fun talking with your faculty and the residents and the research staff and fellows. I'm gonna split the topics because I know Juliet was talking about photoreceptor transplantation. I thought it's only fitting to talk about the RPE work that we've done. Well, that's a little bit in the past, but some of it's ongoing at NEI. But I'll tell you about the OCTA work that we're doing as well, which I think those of you who find imaging interesting hopefully will find interesting as well. So financial disclosures, I'm a consultant for Zeiss, but not directly relevant really to what I'm going to show you here. So for those of you that don't know, I think everybody here probably does, OCTA allows us to look at capillary level resolution images in vivo, FDA approved. And so since it's been FDA approved for almost 10 years now, I think it's really allowed us to look at things, vascular diseases in a different way. And it's really, and I emphasize this to the residents and fellows when we were talking, it's really important to realize that we're looking at cellular level things in the retina. We're looking at individual capillaries, we're looking at individual photoreceptor cells. So try to keep that in mind as you're going. But with OCTA, we can look at the capillaries in the various layers, right? The superficial retinal layer, the deep retinal layer, and the choroid capillaris. And I encourage you to do this on a retina, especially now that it's got a CPT code and you can bill for it. I encourage you to do it on a regular basis and not just when you're curious about something, because like a lot of other things, it actually comes with practice. And one of the advantages of OCTA is that you can follow people longitudinally with it, right? It's not like an FA where you only do it once and then it's done. A lot of the value in OCTA comes in looking at change over time. If you're not sure that's a CNV lesion, follow them a few times with it, see if it changes, see if you can get a better image. And so it's really important to do that, have the normal image up. But in general, I think looking at chronic diseases, neovascular age-related macular degeneration, diabetes, all those things make sense. We started out using this and characterizing diabetics when it first came out before it was even FDA approved. And it's clear that you can see all of the microvascular lesions in diabetes using OCTA. You can see the ERMAs, you can see the microaneurysms. A lot of people like to look at the areas of impaired perfusion. And one caveat that I'll give you is that the finer the lesion you're looking for, the smaller the field size you should be using. So if you're looking for a really small CNV, like in that patient that we were looking at earlier, you shouldn't be doing a 12 by 12 field or an 8 by 8 field. You should be doing a 3 by 3 field right over it, because the resolution is what's going to help you get that lesion diagnosed. But the most obvious thing people look at with OCTA is like, well, look at these areas of impaired perfusion, right? It's kind of like a no-brainer in diabetics. You know there's microaneurysms, you know there's areas of impaired perfusion, dot blot hemorrhages, and this is kind of the most obvious thing. And so a lot of people do it, and clinically it's very useful. But what I'm going to tell you about today is some research applications that we've kind of developed over the last 7 to 8 years. And it comes from looking at patients like this. It comes from doing exactly what I said, which is looking at images of people that you might not have a exact suspicion that there's a definite lesion there. But this is an example of a diabetic, mild to moderate, there's really not much disease in the back, microaneurysms and maybe a dot blot hemorrhage. But what happens is when you look at these patients, what you see is there's lots of lesions, actually. There's actually impaired capillary perfusion all over the place. And you're just not seeing it clinically because obviously you can't look, at capillary level. And we started noticing this a lot. This is from, I think, 2015. And I was doing it on a research protocol. So I was like, wow, all these diabetics that have no DR, they actually have DR. We just don't call it DR because we don't see it. And so that kind of sparked my interest. And it becomes difficult because what are you going to do with it? So we teamed up with Ricky Wang's group, a biomedical engineer who actually was pioneer of one of those CTA platforms. And he had developed some ways of quantitating these images. So a lot of you have probably seen these in some form. You can kind of binarize these images, look at the capillary or the vessel area densities. You can look at the skeleton densities. And it gives you these quantitative tools to then start looking at those images and those areas of impaired perfusion a little bit more carefully. And so what I'm going to tell you about is how we've kind of used this, not only in diabetes, but in some external ophthalmologic application. So what we were able to show early on is that if you actually look at patients who have diabetes, and this top row is a raw OCTA image, the bottom row is a binarized image, you can see progressively increased areas of impaired perfusion. And what's important here is that even if you quantify it at the stage of mild DR, it's actually significantly different. So patients who have mild DR, the ones who have one microaneurysm on your exam, and you see once a year because they really don't have the big problem, they have a significantly different capillary density in many cases than their normal age matched controls. So there's disease there. We're just not seeing it and we're not doing much about it. And that kind of made me wonder, can we use OCTA images, vessel skeleton densities or capillary density measures to stratify this disease a little bit better? And it turns out that you can. So this is the result of a bunch of papers that we put out. I'm just kind of giving you the highlights. Is if you just take vessel skeleton density or the capillary density of an image and you provide the gender and the hypertensive status and the hyperlipidemic status of a patient, you can actually predict with reasonable sensitivity and specificity whether that patient has referable DR or mild DR without knowing anything about their diabetic status. And the AUC here that you can see, if you just look at the model with gender, hypertension, hyperlipidemia, you get an AUC of 0.69. The more OCTA variables you add, the higher your AUC goes until you get to almost 0.9. So, which is pretty impressive to me. I don't know about you guys. You don't know the patient's diabetic, but you just give some general background medical history and an OCTA of the central 3 by 3 millimeters of the macula, not the whole macula, not the whole wide field image, just the central 3 by 3. And you can predict with 90% sensitivity or 90% sensitivity. Specificity is lower. It's like in the 70s, but that's pretty darn good, right, for a screening tool. And I think that's where you're going to see OCTA start going. A lot of the manufacturers have metrics out, but they're just not approved yet, at least in the US. It turns out the same thing is true in other retinal vascular diseases. So if you look at patients who have a retinal vein occlusion, even if the vein occlusion is outside of the central macula, the capillary density in the central macula, in the central 3x3, is probably lower than you would expect it to be. And the capillary density in the other eye is usually lower than you would expect for the age-matched control. So there's a lot of disease going on there that you wouldn't expect. And this paper out there showed it. Obviously, if it's really severe, you see the bottom. But if it's not so severe, you see the top. And it could be completely outside the macula, but you still pick it up on OCTA. So we did a bunch of these studies. We did the same thing in quiescent uveitis, by the way, and published it. We asked our uveitis experts to send us their quiescent uveitis that had no vascular involvement because we thought that would have some vascular component. And it turns out, actually, if you look at them, capillary densities are lower than you would expect, even if they're well controlled on whatever medication. That was with Narsingh Rao. So this kind of made us think, well, what is going on with retinopathy? And at the time, a couple of papers like this came out where they were looking at cognitive decline. And they'd shown that patients who have retinopathy, any kind of retinopathy, have a significantly higher chance of developing cognitive decline as measured by some tests like word fluency or digit symbol substitution than patients who don't. And that's after you control for diabetes and hypertension and all the things that we know cause retinopathy. So that's kind of interesting, right? Why would that be? And in fact, it's pretty powerful. Well, the working hypothesis at the time was that patients who have this microangiopathy or retinopathy actually have capillary level damage that's ongoing, much like that in early diabetics, that we're not seeing, but it reflects what's going on in the brain. And so by chance, I managed to team up with some people from neurology and radiology, and through an NINDS funded program, we studied this. But I want to just point out the rationale for looking at cognitive impairment and dementia is that while a lot of it is involved with Alzheimer's disease, there is a large proportion of people who have microvascular disease in the brain that's just undetected and really unresolved because you can't look at it with MRI or PET. And so the rationale for what I'm about to talk to you is the neurologists came and we were talking, they're like, we really need a way of looking at microvascular disease in the brain. Can you guys do something? And I thought that was really interesting. And so we actually started to work on it. And so some of the work I'm going to tell you is not about diabetes. Actually, most of the work is not about diabetes, but it's how we translated OCT angiography to help study what is vascular dementia, or is commonly known as vascular dementia, and cognitive impairment. So this is the study that we became part of. It's a whole group of MRI physicists, neurologists across the country, and we incorporated OCTA imaging into their consortium and their protocol at several sites, which was a pretty difficult task. And the first thing we ended up looking at was a bunch of people at one site who had actually been classified by neurologists as cognitively normal or abnormal. They'd undergone whole batteries of tests, and we did OCTA of their eyes and looked at the density of the capillaries compared to what their cognitive assessments had been. And this was a pretty small study. It was about 50 people. And you can see the incidence of kind of vascular comorbidities was higher in the cognitively abnormals, but overall, not dramatically different in the two groups. And these patients, just for the sake of understanding what the clinical ratings are, had undergone a CDR scale, which is called Clinical Dementia Rating Scale. It's 0 to 5. And basically, if you're anything but 0, you have some kind of abnormality in your cognitive functioning ability or day-to-day functioning that is abnormal. And this is used in neurology pretty extensively. And what we found was kind of blew me away because I thought this was going to be the end of our study and we were just going to go back to diabetes. But it turned out that people who were in the higher 1/3 of the capillary density spectrum actually were fine. They were all almost CDR equals 0. But the people in the bottom 1/3 of the vessel density measurements had a very high prevalence of cognitive impairment by neurologists. And this was done completely separately. Neurologists were working on these people over there. We had no idea who was coming in. And this is not really like they're demented. This is just that they're not functioning normally at some scale. And so we actually kind of looked at this. We published it. And it turned out if you look at the odds, and this is a small sample size, but there was a 4-fold increase odds of having impaired cognition, not being symptomatic, just having impaired cognition on a test, compared to those for those who were in the lowest tertile of the capillary density measures, which kind of blew me away. And then a lot of people criticize CDR scales because it's subjective, and they're like, well, this is a small sample size. So we said, okay, that's fine, but I was kind of intrigued. So we looked at another cognitive test that the neurologist told us to look at. I said, okay, let's look at MoCA, and those of you might remember what MoCA is all about. And the interesting thing about MoCA is that it tests different domains, and there's domains in MoCA that are actually associated with vascular cognitive impairment, and those are the visuospatial and executive functioning domains. And interesting enough, when you look at the correlation of capillary density with MoCA, there was a significant correlation. It was not, huge, but there was a significant correlation. And if you actually enrich the population for people who have vascular disease, diabetes, hypertension, all those things, correlation gets stronger and more significant. So I was like, at this point, well, there might be something significant here where we're actually measuring some substrate of cognition in the brain through the vasculature in the eye. So, and in fact, if you look at the portion of the MoCA that's driving this association, it's almost completely the visuospatial executive domain, which is kind of your executive functioning type of test. So every other domain we looked at didn't have that correlation. So like, okay, this is pretty interesting, and I still kind of couldn't believe it. So we teamed up with people who were part of the African American Eye Disease Study, Dr. Suzhen Zhang, and we said, let's take a look, cohort of totally different people. The last cohorts we looked at were Latin Americans, Latinx, and now we said, let's look at some African American subjects who had been really well characterized, studied for 10 years, pick some sample out of these and look at if there's correlations between their retinal imaging, capillary density, and their cognitive functioning. We did this through a completely different set of cognitive tools. So NIH Toolbox is a completely different set of cognitive tests, which tests similar domains as what I showed you before. We got lots of MRIs and lots of other characterizations of the patients. I won't go through all the details, but in about 100 people where you're testing their ability to do things that involve executive functioning, capacity to reason, thinking abstractly, you can actually demonstrate there's a significant correlation between the capillary density in the retina and those abilities on NIH Toolbox, which is kind of standardly available to a lot of people. And it's true for multiple different tests in NIH Toolbox. In contrast, if you just test people for what's going on with crystallized intelligence or memory, which is kind of what you've memorized, the association doesn't exist, which was actually pretty surprising to me as well. So it's clear to me at this point, based on two different cohorts, and we have another cohort as well, that there's some substrate within the measurements of capillary density in the retina that is actually correlating with some aspect of cognition, and we don't know exactly what that is. One way to kind of approach this was, well, is it simply a measure of perfusion in the brain and out of the brain, and the eye is being fed by the carotids, and so the same perfusion is happening. And so we looked at measures of intracranial perfusion, and that's pretty hard to do because those measures only happen in the larger vessels, and so it wasn't necessarily a fair comparison. So we ended up looking at other measures that are not clinically used, but research measures of white matter integrity in the brain. So mean free water is a measure of diffusion of water in the white matter tracts, and peak skeletonized mean diffusivity is a measure of integrity of the white matter tracts in the brain. And if you actually look at both of these measures, there's a very significant univariate correlation and multivariate after you adjust for age and gender and other things with the capillary blood flow in the back of the eye. No matter how you measure it, whether you measure it by flux or skeleton density, it's significant. And so that was actually really proof positive that what's going on in the capillaries is somehow reflective of what's going on in the brain vasculature. And so what we wanted to do was try to address this question of what's the mechanism by which this is happening. And through this kind of consortium that I was part of, it became clear that ApoE4 is one of the leading kind of causes or associations for cerebrovascular and cardiovascular disease associated with hemorrhagic stroke and vascular cognitive impairment. And people who have, obviously this mutation can be well characterized. And it actually turns out that a mouse model was generated around that same time in 2018, demonstrated a mouse model where the transgenic mice that has a human ApoE4 mutation actually has decreased intracranial blood flow. And not only that, it has decreased capillary density no matter how you measure it, whether you measure it by area or number of capillaries or the number of capillaries here. And so we were like, wow, this is really interesting. What if, this ApoE4 is mediating some kind of capillary perfusion change that we're measuring in the eye that's also happening in the brain? And so what I'm going to end up with for this OCTA portion is to say we actually teamed up with a group at University of California, San Francisco. Fanny Elahi was there. And we looked at a cohort from their long-term aging and memory study. So we had 163 people. We were doing concurrent OCTA imaging. They were doing all their own assessments of the cognition and PETs and MRIs completely separately. And we were able to identify about 75 or 80 people who had both OCTA testing, genotyping, MRI, PET, all the kind of testings we needed to exclude other neurodegenerative diseases. And again, remember, these are actually healthy people without cognitive complaints, right? We're just looking for the effect of ApoE4. And if you look at these density maps, which is kind of like eye candy, but it gets the subjective point across. The top is an ApoE4 non-carrier, and the hot spots measure areas where there's relatively higher capillary density than others. There's fewer of those hot spots in the ApoE4 carrier than in the non-ApoE4 carrier. And so that was actually, that held out when we actually did the statistical analysis, and after you adjusted for gender and other comorbidities, you actually saw there was a significantly decreased capillary density in the ApoE4 carriers than in the non-ApoE4 carriers, even if they only carried one allele. 2 alleles is pretty rare. And what was quite similarly interesting was that their association between capillary density and age was most significant in people who had the ApoE4 allele, meaning that there's some decline in capillary density that might be mediated by ApoE4. It's obviously cross-sectional, so we don't know. That could be actually mediating the effect that we're seeing. So we're actually looking at a much larger cohort now. We teamed up with the Framingham Heart Study. We just imaged about 1,000 people in Framingham with OCTA, and we're kind of working to characterize that cohort and kind of dig into the systemic associations as well as the cognitive associations in that cohort now. So I'm going to kind of end it there and ask for any questions on this topic before I move on to a second one.
Hi, thank you. That was really fascinating. I'm just curious, is this the use of the OCT angiography, is that being used in like the clinical trial setting to look at response? I don't know if there's neurology trials looking at treatments for dementia or something like that, but is this a useful tool sort of in the clinical trial setting to monitor response?
So response, that would be that would be amazing. I mean, I don't think that neurologists needs help diagnosing or managing dementia when it's fully blown, or even cognitive impairment when it's clearly there. But one of the things we were doing with Mark VCID was trying to see if we can use it as a tool to enrich populations for risk that they're enrolling into clinical trials. Because as you can imagine, imaging for these trials is very labor. You got to do MRIs, you got to do PETs, you got to lumbar puncture, you got to rule out amyloid. And so it's very hard to do large-scale studies in neurology because it's hard to risk stratify at the beginning when patients are least symptomatic. So that's where I think this comes in handy, is you get in early enough that you can actually provide some metric for, are these people a higher risk people in your cohort, and are they improving, or are they getting worse? That's where we're going with it. It's obviously much harder to say than to do, much harder to do than to say.
The variables that you showed that predicted the diabetic retinopathy was impressive. I guess the obvious question is, and now that you're getting so many images, are you using AI to start to look at some of these and seeing how they can help predict future disease in these patients?
Yeah, I think there's definitely a lot of people doing that. We're not doing it ourselves. I think one of the challenges has been that OCTA has evolved so quickly over the last 10 years, from spectral domain to swept source, small fields to wide fields, that the continuity of data is pretty poor. And so it's very hard to train data because, it's trained algorithms because there's not a consistent historical data set, which is one of the reasons why we went to large data. One of the reasons we teamed up with Mark VCID and Framingham, because there was just no other data set to work with. So we're trying to develop those data sets, but obviously it's a way to go. The problem with diabetes is that it's such a chronic disease, right? If you wanted to show change in diabetes from the point where people have no retinopathy to the point where they have, some kind of retinopathy, you're talking, years, right? So that becomes very challenging, which is, we're doing a longitudinal study now. It takes forever, and the numbers need to be huge because we're looking for very small effects. So those are the challenges of doing that.
So I like the idea of looking at the vascular diseases in the brain. Obviously, we're Dr. Rajiv Ramchandran working with us. He's been looking with Steve Silverstein at various psychiatric disorders to see the correlations can be. So this is absolutely fascinating technology.
I know Kyle was working on that. So yeah, telling about it. It is. I think that there's a lot more to be explored.
Great talk, Amir. I was just curious, saw a lot of nice work with the vessel density and skeleton vessel density. Did you look at flow density as well? And I'm also curious, do you think the clinical availability of some of these metrics, like easily available, we should hopefully be coming soon with our OCTA packages and whatnot?
Yeah, so the language and terminology is very kind of confused. So flow density, perfusion density, capillary density, the underlying measurements are almost all the same, which is that you're looking at the variance in the backscatter from individual blood cells. So you're looking essentially at a range of blood flows that the machine can detect. And from the best estimates, we have something between 0.3 to 3 millimeters per second. And that's a pretty wide range. So you can still have really slow flow and not detect it. And you can have fast flow and not detect it. But you're looking at perfusion. So flow density, I don't know how different that is than perfusion density or how different that is than capillary density. Depends on which manufacturer you're talking about. But essentially, I look at it as the presence of physiological flow in the capillary at the time of the image. So that's one thing. The other thing is, it puzzles me a little bit why the FDA hasn't approved the metrics in the United States. They're approved in Europe, and I think even in Asia on some of the platforms. My guess is that the reliability is just not as great, especially across devices. And so I totally believe that. We still do all our own in-house analyses and quantifications with software we developed with Ricky for that reason. So.
I noticed you used the Zeiss in the beginning, but then it went to the OptiView later. Is that kind of your...
No, we've been using Zeiss the whole time.
Oh, you do Zeiss the whole time. Oh, okay. Gotcha.
Yeah, for consistency's sake, as well as they have a wider field, and they have the only swept source. Well, they had the only swept source platform when we started.
Yeah, thanks for the talk, Amir. Could I ask, where do you see the kind of technological developments coming in the future with OCTA? I mean, you have everything you need. What do you think would be the next steps?
Yeah, so I think the next steps are, the interesting thing is almost all the work that we've done has shown that just the 3 by 3 millimeter scan is really enough to get most of the predictive and diagnostic power. The field is moving a lot towards wide field because that is of obvious interest for other things. But I don't think it really takes much more than commercial interest and, frankly, to be very honest, reimbursement for the imaging modality. Because until this month, OCTA was not reimbursed. And so for a disease that is defined by impaired capillary blood flow, we haven't been able to measure capillary blood flow forever, and now we can. So it kind of boggles the mind that wouldn't be useful in assessing these patients, right? So yeah, but I think it takes reimbursement, and probably now my guess is you'll see the perfusion parameters becoming more more push to get them FDA approved than on the US platform.
Thanks, Amir. Why don't we go on to the second speak?
Sure.
That's great. Thank you.
Great. All right. So the second talk is on a totally separate topic, but hopefully one that um, most of you find interesting. And it's really been a adventure and a very exciting experience. So right now, I want to just make clear, I'm working with Kapil Bharti's group, the same group that Juliet described earlier, where we met down at NEI. They have a study using iPSC-derived RPE in humans. It's a phase 1/2 study, and that's the study that's currently ongoing. I can't talk much about it because it's ongoing, and so we're still waiting for data to come out. But I thought what would be good is to talk about the previous experience where I was PI of the first-in-man human embryonic stem cell RPE transplants that were done in the United States and actually, I guess, yeah, first or second in the world. And so this was done at USC with Marco Mayun, Dennis Clegg, and David Hinton at the time. And it was really an amazing team. So I just want to acknowledge the tremendous amount of effort from all these people at University of Southern California in doing this work. Again, my conflicts are not really relevant. But as most of you know, there is no treatment for preventing dry AMD. There's now complement-mediated therapy, anti-complement therapies that slow the progression of geographic atrophy, in addition to kind of the vitamin therapy that slows the progression to more advanced forms. But there's really nothing that treats the area of the atrophy that has developed. And so one of the goals, as Juliet is doing, is to develop cell-based therapies to try to treat these areas of atrophy that occur inside the boundaries of the RPE loss. And so this is actually the idea of replacing RPE in areas of atrophy seems kind of counterintuitive because a lot of people say, well, there's no photoreceptors there. Why would you put RPE there? And it turns out that there are probably photoreceptors during some window of opportunity that we have poorly defined, during which time, if you replace RPE, you can probably restore some visual function. And so the goal is to try to do that. And actually, people have done that. We just kind of all forgotten about it. So in the 90s and early 2000s, several groups actually did autologous translocation of the RPE, which looks horrendous. But I'm just showing it to you because the reason it didn't work was it was such invasive procedure to harvest this RPE in vivo and then put it in the subretinal space. You can imagine the kind of manipulation going on is damaging the RPE. Not only that, it's technically very difficult to do that, and now you got to put it in under the macula in the area of geographic atrophy. These RPE are from the same patient, so they may have genetic predisposition to developing atrophy to begin with. And so all of these things led to this not working, in addition to the fact that people developed really bad PVR detachments after those huge wounds were made. But even in this case, so this one subject here went from 2050 to 2030 after that subretinal RPE implant. You could argue that's within the range of kind of normal variability in vision in GA, but it was clear that it's feasible to actually do this, and it's clear that it did improve at least some small cohort of patients. The main problem was the difficulty in actually harvesting and delivering the tissue to the right place. So do we have to evacuate the building? So when I was at USC, Mark Amaya and David Hinton and Dennis Clegg had developed a patch using human embryonic stem cell derived RPE that kind of avoided the whole portion of harvesting the cells. So you didn't have to harvest the cells anymore. And the idea is to just go in and create a bleb and put the new cells in the area or around the area of atrophy, and to see if that is safe and feasible, and if it does anything to restore any amount of potential vision. And obviously, the cover article on the right shows you that we did it. I'm going to go through this study briefly and tell you a little bit about the study that we're doing at the NEI without hopefully going over time. Yep. So this was a phase 1 open label study in about 20 patients, ages 55 to 85. Everybody in the study had severe GA affecting their central vision, and we only worked on the worst seeing eye, and had one surgery with one implant at the beginning, and then were followed for up to 5 years. The implant in this particular study was about 3 by 5 millimeters, had human embryonic stem cell derived RPE that was cultured on a substrate, kind of like Juliet was saying, an inert perylene substrate. And this is a 1 cell layer thick implant. So it's pretty impressive that you can develop this and differentiate the cells with this kind of precision. But the implant looks like it does on the right-hand side of the screen. It's pigmented. It's got a little tab to help with the surgical insertion, as I'll show you. And it is delivered by an injector of the type that you see here. This was custom-made injector for this particular implant. And the goal of the injector here is to actually protect the implant while it's being delivered. So unlike the previous surgery where the RP cells are kind of flapping all over the place, they're being manipulated, we wanted to avoid that. And so this was the tool that was developed. It was, again, a trial where we were, phase 1 trial where we were recruiting patients with fairly poor visual acuity. So 2200 or worse in the first half of the cohort, and then 2080 to 2400 in the second half. But we never really got to 2080 just because of the logistics of the trial. So everybody was 2200 or worse. We did immunosuppress briefly with tacrolimus, starting about 8 days before surgery and going to about 2 months after surgery, with at least 12 visits in the first year and then annual visits follow-up. So here's the example of one of the surgeries I'm showing you. Intraoperative OCT was available for half of these cases. And so I'll try to talk through some of these. So here, this is just the first case going fairly quickly to see the bleb has been made. Here's the implant going in. The implant in this case is actually rolled up. And when it goes into the subretinal space, it opens up. So intraop OCT shows nicely that it's in the subretinal space with the bleb there. You can see there's some areas of subretinal adhesion. And you can actually flatten that out with PFO, and you can watch it being flattened out. You can see the implant on that side. And we're kind of scrolling through and checking. You can see how thin the overlying retina is in this particular case. One of the things that I will say is that, it's really important in these kinds of cases, which is one of the things I was asking Juliet, to be able to target the dissection to the area that you're interested in, right? Because you didn't necessarily in this case want to put the implant out in the periphery. You wanted to actually be able to get it to a particular region. And maybe the center of the GA is not the most important, but get it within a particular region of the GA. That's why we're placing it within the GA, just to be able to target it. Here's another example of another patient where the intraop OCT is really nice. You can visualize the bleb, and it also actually shows you a lot of what's going on in the subretinal space. You can see some subretinal adhesions here, and you kind of scroll around. In some cases, there's large PEDs that you want to avoid. And we're actually, in these cases, doing this targeted subretinal hydrodissection. You saw me doing it there, to actually create a bleb in exactly the region that we want to do it. We're not letting the bleb grow indiscriminately, because most of the time it'll grow in the wrong direction. It'll grow away from the GA, and then you'll get a large peripheral detachment. So here you can see the implant going in again. It's in the subretinal space. You can see that we're going to flatten it shortly. Here you go with the PFO. And let's do an air fluid exchange. And the last example I'll show you here is similar, but in this case, you can see there's a little bit of a PED that develops. If your infusion goes a little bit too deep, then you get small PEDs. You have areas of adhesion. Again, we did the first half of these without intraop OCT, so it's doable. It's not absolutely necessary. There you can see a little bit of that PED is developing, so you want to stop your subretinal injection there. And then here you're going to see again, we're scrolling through this area of the bleb, making sure that we kind of understand what the subretinal anatomy looks like. And then you're going to see a little bit more subretinal hydrodissection to try to separate that region that you're looking at. This patient actually had no fovea to begin with, because the outer nuclear layer was completely gone. So here you can see the subretinal hydrodissection that we're doing, and you're just gently trying to elevate that area of GA. The GA ends up actually being scarred down, which is very hard to create in an animal model. And so there's really no similar way of mimicking it that I've seen. But in any case, that takes some effort. And here you can see the implant going in again. It's folded when it goes in and then opens up in the subretinal space. And that tab I was telling you about earlier is for this kind of situation where you can actually grab it and tuck it in without having to touch the rest of the implant. So the surgical methods actually are published, and there's some surgical videos in there. Again, we enrolled 16, implanted 15, used intraoperative OCT in half of them. We were able to target the implant to the area of the GA for all the cases, essentially. And the duration ended up going down to about 2 hours, which is feasible for an outpatient surgery. But obviously, the first few cases took a lot longer. I'm just going to skip that because it really doesn't say much. So here is the fundus photographs of all of the first 15 patients in the study. And the first 6, nobody had an unexpected severe adverse event. And so that was great. We did have intraoperative hemorrhages and some perioperative hemorrhages that you can see in the first 6. And that was primarily from tolerating vitreous hemorrhage that you would normally tolerate during vitrectomy. You don't necessarily clean up every last bit of blood during surgery and vitrectomy. And it turns out that, you don't want to do that in these cases. You want to be really meticulous and have zero tolerance for any kind of oozing at the end of the case, because that ends up going into the subretinal space and that ends up causing long-term problems. And so for that same reason, we actually had to exclude people who were on any kind of blood thinner after the first 6. But with those interventions, the subsequent 9, we really didn't have hemorrhaging problems or adverse event. And so you can see the implants there at 1 month. This is the follow-up of 1 patient over the full year, and the 1-year follow-up has already been published, as I mentioned. The key points for this were the implants never migrated. They were in the same place the entire time. There was no evidence of vasculitis or cell or vitritis or choroiditis that one would anticipate with rejection of the implant. There was some hemorrhages, and you can see some subretinal fibrosis in the patients that did have those hemorrhages early on, which is why we wanted to avoid those later. And amazingly enough, the subjects after 3 years, the 3-year follow-up just got published a year or 2 ago, it was promising and certainly demonstrated the safety and feasibility. So among the patients among the eyes that got implanted, about a quarter of them demonstrated improvement between 7 and 15 letters. And this is in contrast to 0 eyes, the non-implanted eyes that improved. So none of the non-implanted eyes improved. And 60% of the eyes that were actually treated either stayed the same in terms of vision or improved, again, compared to 20%. And what's not surprising is that 80% of the contralateral eyes that were not implanted continued to lose vision between 8 and 21 letters over the 3-year period. So definitely not powered for efficacy, but promising in terms of efficacy. One of the interesting things about this was that all of the subjects in the study were greater than 50%, were mismatched at greater than 50% of the HLA loci that we looked at. These were obviously allogeneic cells. They were from a different subject. And so you would worry about some kind of immune response. But without any HLA matching and very mild perioperative immunosuppression, we were able to manage what you saw. So one of the patients passed away 2 years after they enrolled in the trial, and that was from unrelated causes, just normal cause of death. And in that patient, we were fortunately able to obtain histology. And here you can see that the RPE is actually present at 2 years. It doesn't look like there's a lot of fibrosis around it. The perylene membrane is there. The cells are still pigmented. And there's still markers of RPE65, as well as some markers of RPE polarization overlying the membrane. And interestingly enough, some markers that David Hinton was convinced demonstrated phagocytosis or phagocytotic activity of those remaining RPE cells, where the yellow and the green are overlapping. Interestingly, this also happened to be over a region where there was a rosette, some rhodopsin positivity. So there's a couple of regions actually in this patient. So at the very least, we know these cells survived. We did look at immune response in this eye, and there was actually very little evidence of a directed immune response to the implant. There was CD68 positive cells, but no more than in the contralateral eye. You can see here. There was CD8 positive cells, but again, not targeted at the implant or surrounding the implant. And again, no more than what we saw in the contralateral eye of the same patient. And CD4 positive cells in the same kind of distribution that actually, some of which co-stained with FOXP3, suggesting that they could be T regulatory cells. There was lots of gliosis. One of the worries that we had was that there would be fibrosis or gliosis around this membrane, indicating some kind of immune response towards it. But all the gliosis was above the membrane where we placed it. There was no evidence of encapsulation, even at the 2-year mark. And here you can see the implant. This is the implant down here, and the RP cells are above it, and the red indicates the GFAP staining above that. And trichomason staining, again, looking for the collagen underneath the implant where presumably ingrowth of, we're going to show you in a second, ingrowth of some CD31 positive structures indicated there could be capillary-like structures underneath this implant because of the VEGF drive, presumably driving some revascularization. And so that would bring in some of the collagen staining as well. So overall, let me see if this is going to, so here are the small capillary-like structures underneath the implant, which we were calling neochoriocapillaris at the time. It seemed to be driving a vascular response to help feed the implant and provide nutrients. So overall, safety, efficacy, safety was shown, feasibility was shown. We refined the surgical procedure. We didn't see any clinically significant immune response in the patients that we implanted. And I think the phase 2 study is actually about to get underway. So just by way of very early information, we're doing the same type of study with induced pluripotent stem cell derived RPE with Kapil-Bharti. This is on a PLGA scaffold, which is a biodegradable scaffold that disappears after about 30 days. And so that's obviously advantageous in different ways. These cells, much like the other cells, are fully differentiated RPE. They're going in, expressing all the markers that you would express, you would want fully differentiated RPE to express and look like healthy RPE in their morphology. And I'm going to show you, Juliet already showed you this, so I don't have to show you this, but I'm going to show you one surgery in humans, the first surgery that we did back down at NEI with, again, different kind of injector, same kind of surgical technique, slight modifications for the instrumentation and the size of the implant. But again, this is a hydrodissection underneath the retina. In this particular surgery, originally we were trying to target it to the edge of the GA, but we decided that putting it in to cover more of the GA is probably a more sound surgical approach. So you can see the implant going there. This implant doesn't fold. It's actually just a flat implant. It goes in through a slightly larger retinotomy, but in this much the same way as the previous one. There it is in the subretinal space. And again, there's the subretinal position after the PFO installation. And so the kind of stuff that Juliet's talking about is just around the corner, because we're going to be putting in photoreceptors pretty soon. All right, so this is a collaboration between NEI and the Wilmer Eye Institute. And so that was the first autologous cell treatment in the United States that we did back about almost 2 years ago now. And we're implanting the next patient next month. So we're moving slowly forward, but happy to take any questions. Five minutes to spare. Yeah. Yeah, so you don't need to do that in a lot of cases because you're looking to put it in, you don't necessarily have a target. But one of the reasons I asked the question about whether you can find the places that you had lasered is that, you know, it's not necessarily trivial to get the bleb to go to that spot so that you can then get the implant in that spot. And so that's what you would want to do with this. And the Lambert is commercially available for Med1. It does restrict the regions which you can access, but you guys are, you know, lasering in the posterior pole or lesioning in the posterior pole, so it should still be doable. And yeah, the technique does allow you to localize a bleb rather than just, because if you just you've probably seen it. If you just start a bleb, sometimes it goes that way, sometimes it goes that way, sometimes it goes backwards, and to some degree you can control that with the angle of the subretinal cannula you come in with, but sometimes it's just, you know, it's just going different direction. Especially the larger the bleb gets, the harder it is to control the direction it grows in, because the amount of pressure you're putting in. McLaren has shown this really nicely, right? So. Yeah. I mean, I'm agnostic to it. I think that there's methods to use both. I think cell suspensions are actually still a feasible thing. It's just not necessarily for treating large areas of atrophy. Right? So I think as surgeons, we have to be open-minded to the approaches. Each of them does have pluses and minuses, and you know, you need a head-to-head trial to see if one is better than the other or different than the other, and we're barely even there yet. So I don't think anybody should be saying this is better, this is worse, or this is, because I certainly don't know. But I think it's great to, you know, try them and see what happens. So. Well, the problem is that the vision is so low that you have a very hard time. I mean, ERG is not going to tell you much, right? So because you're covering a small area. The multifocal ERG, you're going to need really good fixation, and you're dealing with patients 2200 or worse. Microperimetry is the same problem because you just don't have enough fixation to get a good baseline to then know. We actually did microperimetry on a couple, and it's part of one of those papers. So the fixation improves in the eye, and then, you know, we looked at the 2 degree and the 4 degree area. The problem with the microperimetry is partly that the fixation in the contralateral eye improves too, and it's probably a byproduct of the way microperimetry testing is done, which is that the fixation component, because patients learn to look straight ahead pretty well. If you keep telling them to look at the target and the target is always straight ahead, then they just get really good at looking straight ahead. And so that's the only reason I could find that both eyes would improve. I think it was insignificantly different how much they improved in the implanted eye, but we only had like 2 patients or something. So it's hard. Basically, it's hard to do when your baseline is so bad. So, yeah.
What ideally?
Yeah.
This is
Yeah.
totally theoretical.
Yeah, I mean, I don't know. I think when I started doing this, everybody said, "Why are you putting RP where there's no photoreceptors?" And my response was that I think it's a important milestone. But we had a couple of patients actually improve quite a bit, right? And so I think there's a window. I think there's a window of opportunity during which RPs is sick or gone, and there's still viable photoreceptors there. And I think the earlier studies, either macular translocation or otherwise, support that. A couple of our patients support that. And I think there'll be more data that kind of supports that idea. The question is, at what point, what's that window? What's the end of that window before? If there has to be definitive atrophy, and it doesn't involve the fovea, you're going to have 20/20. I mean, you could have you have 20/20 until they're, it's wipe out except for the central island. Is it helpful to implant that patient? Would that patient prefer to have had more of a field and less of a 20/20? I think it's an open question. I think it's going to be a tough one to answer. But I think we're getting to the point where safety and feasibility, I don't think are issues. I think you can get them there. I think we have to figure out the immune response a little bit better. So hopefully with additional studies, but the feasibility is there. I think the safety is there. It's just a matter of picking the right opportunity and defining it. So it's going to be tough. I don't have the answer for that.
A change in the choroid capillaris after transplantation?
Yeah, so that patient clearly demonstrated that there was vascular structures underneath the implant in a previously completely barren area. There's no question that there was vascular structures. Now, I don't think that is CNV as we would conceive of it clinically, so I try not to call it CNV because that invokes all of our baggage with what's current CNV is, right? I don't think we should be treating these patients with anti-VEGF, for example, right? Because that's the logical next step. But I think that is a result of the implant secreting VEGF from the basolateral surface and essentially driving a vascular supply to itself so that the cells can actually have blood supply. Otherwise, there's nothing there. So, yeah.
Yeah, actually, I get the answer. I just want to ask, you're working on very atrophic area, the retina is very atrophic, and is there any, have you ever seen choroidal neovascular membrane after this surgery? Because Bruch membrane trauma maybe can cause neovascular membrane in this area. The question is, my first question is this. And the second one is, embryonic stem cell is legal in the United States. I don't know, in my country it's illegal. And have you ever tried to induce pluripotent stem cell to produce retinal pigment epithelium cells?
Yeah, so this team right here, the one led by Kapil Bharti at the NEI, is doing it with induced pluripotent stem cells, and those are the ones we're implanting now. The earlier study was human embryonic stem cell. But that being said, it was with an approved cell line that, it wasn't like a legally manufactured. But it's a good point. Your first question I missed. What was the first question? Yeah, so Bruch's membrane trauma, I think that Bruch's membrane is heavily abnormal. So, I don't know, it's already traumatized quite a bit. But I think it's kind of what we were talking about right now is that there are vascular structures underneath the implant, at least the one implant in the patient that passed away. And I think that is a vascular supply to the graft. I don't think it's choroidal neovascularization of the type that we typically think about, if that makes sense.
Amir, thank you so much for sharing your expertise with us today and for sharing your research. It's really impressive, and it's a great model for the residents to follow. And you're really a star in our field, and we appreciate all the work you're doing for us and our patients. And to commemorate your visit here, we'd like to present you with this plaque to demonstrate the distinguished professorship here today.
Thank you so
Thank
much,
you so
guys.
much.
Thanks for having me here. I appreciate it.